Hello, and thank you so much for joining us today for the webinar Acellular Dermal Matrix, a new horizon in periodontal plastic surgery and guided bone regeneration. It is a great pleasure to introduce to you Dr. Andrés Eslava Vanegas, whose aim during this presentation will be to discuss about amazing and predictable results using Acellular Dermal Matrix and xenografts. We would like to thank Dr. Eslava for being with us today and botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Eslava at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Andrés Eslava Vanegas.
Okay. Hi, I want to say good afternoon in America, and I want to say good evening for doctors in Europe. I want to thank to botiss Biomaterials to invite me to this webinar, and especially to International Sales Manager Alba to have confidence in Latin American doctors. Okay, my name is Andrés Eslava Vanegas. I am a dentist from Colombia, from Medellin, Colombia, and I have a specialty in periodontology, oral medicine, and dental implants. I live and work in private practice in Medellin, Colombia. The topic we're going to talk about today is acellular dermal matrix. Especially, we're going to talk about mucoderm. And the topic of today's presentation is mucoderm or dermal matrix could be a new horizon in periodontal plastic surgery and guided bone regeneration. Okay, when we do periodontal plastic surgery, we almost all the time think about connective tissue graft. And it works really good almost every time we use it. We can get, I'm going to put a slide over here. We can get keratinized tissue. We can do root covering procedures. We can get some aesthetics like we can see in this slide. Sometimes we can do root covering procedures like this, but sometimes we can see a little bit of scar over here. And sometimes when we're talking about periodontal plastic surgery, this isn't accepted by the patient or maybe by the other doctors. As we know, periodontal plastic surgery has many kinds of treatment, like connective tissue graft, like epithelial and connective tissue grafts. There is a lot of flaps we can do, slides, coronal, apical, side by side, double papilla, a lot of things, okay? But they not always as predictable as we want they can be. As we can see here, we can see a root covering procedure, but the color is not matched with the adjacent teeth. We can see scars in here. We can see a deviation from the mucogingival junction. Okay, and the color doesn't match as well as we want to. There is a case that has at least 10 to 12 years. There is a patient referred to me by the orthodontics because he has a very thin biotype. He has a root recession, gingival recession. He's in this anterior incisor, and he wants us to do a root covering procedure and increase the keratinized gingiva. At that moment, we were thinking about free gingival graft. As you can see here, this is the normal procedure we do. We do a periodontal flap. We put our gingival graft, our free gingival graft in here and put some sutures in there. After 2 weeks, that's the appearance. Okay, we can see a normal free gingival graft healing. We can see some fibrin here. We can see some redness in here. Okay, but take a look at these borders. Okay. After 6 months of healing, we can see something like this. And this is so common when we use free gingival graft. We can see a gingival recession that could be covered, okay, is better than at the beginning. We can see a wide band of keratinized tissue, but we can see a lot of scars over here. And take a look at this. There was only one free gingival graft, but you can see here a scar Something that happened with this kind of autograft, you can call a connective tissue graft or free gingival graft, if that is that those grafts are going to shrink. Sometimes it could be shrink like 10 to 15 to 25%, but sometimes, especially the free gingival grafts, could shrink like 50% of the beginning. You can see here, 1 year after we do the surgery, we can see a root cover, okay, like 100%, even is better than the other side, but we can see here the color match is not good as we want to, okay? You can see here the scars, okay? You can see the deviation of the mucogingival junction, okay? You can, or we can afford the primary thing we want to do here, that was root covering procedure and increase the keratinized tissue, but the aesthetic is not so good. There is another case of free gingival graft. This slide is not my slide. This is a patient that had this procedure like 15 years ago. That's the pictures that she brings me when they get that surgery. And that was a patient that was going to orthodontic treatment. She doesn't have enough keratinized tissue, so the orthodontist and the periodontist at that time thought that she needs more keratinized tissue. So they do a free gingival graft, a huge free gingival graft like you see in here. Here is how the patient came to me 15 years after the surgery. So you can see here, there is just a part of the free gingival graft. There is a lot of scars. There is part where there is no graft on it, okay? You can see some root covering. You can see here a wide band of keratinized tissue, but in most of the parts, there is nothing, okay? And look at the aesthetics of this son. In this case, this patient doesn't show the lower arch, but you don't want that. You don't want to show that. There is another case. This is Juliana. We're going to see more forward in the presentation a short video of that patient. This is almost the same case that we see on the last slide. Juliana, her parents are dentists, both mother and father are dentists, and she went to orthodontist, and the same story. She needs some keratinized tissue. This is better than the other case. We can see a lot of keratinized tissue. We can see no root or gingival recessions, but you can see a lot of scars in an ugly tissue, and the tissue is so white when you compare with the other tissue. I'm going to talk about this case because more forward in the presentation, she wants me to do the same procedure but in the upper arch, and she has a very high smile line, so she don't want to happen this on her smile. Okay, let's move on. Let's keep talking about the connective tissue grafts. Okay, you can see here a case where there is a gingival recession. Maybe it's a class 3 Miller's class 3 gingival recession. There is no keratinized tissue at this level. There is some papillary loss in gum and in bone loss here in the interproximal. And we can do a flap in here when we can put some connective tissue graft with no epithelium on it. You can see how beautiful can we take these connective tissue grafts. Okay, you can see how what is the width, what is the height of these connective tissue grafts, and what is the thickness of these connective tissue grafts. Okay, we can put in there. We can do a root cover procedure, and we can cover with our flap our connective tissue graft. One of the advantages of these connective tissue grafts is that sometimes you can leave it exposed. Some authors suggest that this part of the graft that is going to be exposed could be covered or could be just epithelialized portion of the graft, or you can let the connective tissue graft exposed. Okay, this picture is from about maybe 8 to 9 years ago, so you can see the flap is not raised so good. There is some tension on this flap, but okay, this is part of the story of this. 2 weeks later, this is the appearance of the healing of this patient. Okay, you can see the papilla are really good. Okay, but in this area, when the connective tissue graft was exposed, you can see this white area. So you may think it could be necrosis or what is going on there, what is happening there in that side. But 1 month later, when we remove the sutures, we can see this granulation tissue in this area. And you can see almost a complete root cover of the beginning gingival recession. And we can get some keratinized tissue. Okay? You can do that with connective tissue grafts. But let's move in. And remember, when we talk about mucogingival surgery at the end of the 90s, at the beginning of the 2000s, we're just talking about gingival recession, okay? But then after, American Academy of Periodontology introduced the term periodontal plastic surgery, and they start to talk about gingival recession, they start to talk about pontics, aesthetics, they start to talk about implant aesthetics. So this is the case of valvas. We're going to see more forward in the presentation. You can see something like this. Look at the defect, okay? And this patient don't want to have implants in that area, okay? So we need to rebuild this ridge for pontics. What can we do? We can use connective tissue grafts, of course. We can do free gingival grafts, of course. We can do onlay, inlay, a lot of tissue grafts to rebuild this, of course we can do that. But how much is from here to here? It's about 5 to 6 millimeters. How many grafts do we going to need to rebuild this kind of defect? Okay, if we're just talking about tissue grafts, okay, or rebuild this ridge. Remember that she doesn't want to go with implants treatment. Okay, let's keep in mind with that. That's Juliana. Remember the girl that I talked about, her parents were dentists. And that's the appearance of the upper jaw. She had a really high smile line, and she had recessions after orthodontics in this area, from canines to molar, from premolar to molar. And look at this very thin biotype. And she wants to do something with that, and she doesn't want to have another connective tissue graft or free gingival graft. And remember, how long is from the first molar to the first molar? How much we are going to need? How much tissue graft we're going to need to do that? Now, let's talk about the grafts that we get from the palate. Some of you maybe have done many of these surgeries. And how many of you have some hemorrhage or bleeding when you take this connective tissue graft? Or even worse, when the patient is at his home or at her home, and the wife or the husband of your patient calls you, doctor, she has a lot of bleeding. It happens not a lot of time, but sometimes, and when just one time that happens to you, you're going to remember forever. Okay, let's talk about how the palate heals. The palate is going to take about 2 to 3 weeks to heal at the first stage of the healing, and it's going to look like this. Okay, there is an irregular borders of the scar. There is a lot of fiber in there. Okay, and if you have a very thin biotype in the palate, could be some exposure of the bone. Of course, it could heal, it could granulate over the scar that you let in there, but your patient must tell you, I'm sure that your patient must tell you, it hurts a lot, okay? And the patient is going to remember you for about 2 to 3 weeks until it heals, okay? So this is the only option we have for our patients. We can do connective tissue grafts for root cover or increment thin to thick biotype, maybe in 1 or 2 teeth. But if you want to do a big case and we want to cover from first molar to first molar in one surgery, maybe the connective tissue grafts are in the option. Okay, let's move. Let's talk about the palatal artery. And remember where is located the palatal artery. Remember that Reiser has his classical study about where is located when he is related with the gingival margin of the first molar. And what he told us? He told us that the palatal artery, it depends of how deep is the palate. So he told us when you have a really deep palate, you have 17 millimeters from the gingival margin of the first molar to the palatal artery that is in this area. When we have a shallow palate, we only have 7 millimeters from the gingival margin to this area. So the mean height from the palatal artery from this gingival margin of the first molar is about 12 millimeters. Keep this in mind. This is year 1996. Okay? How many of you have taken your CBTC scans and shows and try to find where is located your palatal artery in your patients? How many of you have done this before? There is some more in that study from Reiser we have for almost 20 years, and we were just thinking about it. But let's keep moving, let's keep forward. There is another study for Minkevem in 2014, and what he wants to know? He wants to know how thick is the mucosa of the palate, and how thick is in the second molar, in the first molar, in the second premolar, first premolar, and antecanine. And even better, he wants to know how deep or how thick is that mucosa palate at 3 millimeters, at 6 millimeters, and at 9 millimeters. And he do templates and put it on the palate and do these marks that you can see here. Okay. He does something else. He wants to know if the mucosa palate was the same in young patients from 14 to 21 years, or in mature population between 30 to 60 years. There is a resume for canine, premolars, and molars, and here is the mean thick of this mucosa palate. What he found that in young people or in young patients, the thickness of that mucosa palate was about 2.3 millimeters. But in mature population, it was about 2.5 millimeters. Okay, but what he was measuring, when he talked about 2.3 or 2.5 millimeters, what he was measuring? And he was measuring epithelium and connective tissue, or lamina propria, if you want to call it like this. Okay, let's keep moving. There is a lot of statistics in this study, but I'm going to resume in this. The height of that mucosa palate, and when we're talking about height, we're talking about apical to coronal position, or apical or coronal extension of that graft. And the height was 12.3 millimeters. Look, it's so similar that the Reiser study. And What was the width? When we're talking about width, we're talking about mesial to distal distance. And he found that was about 31 to 31.5 millimeters. And remember that the thickness is how thick is that connective tissue graft, or how thick is that mucosa. And he found that was 2.3, maybe 2.5 millimeters in older patients. There is a beautiful histology that he showed us in his study. And you can see here, he took that measure at 3 millimeters, at 6 millimeters, and at 9 millimeters. And there is a zoom of that slide. And you can see that here is the epithelium, here is the connective tissue or lamina propria, if you want to call like this, and here, a huge part of this is glandular tissue, okay? So, we want glandular tissue in our connective tissue grafts? Maybe no. And what he found, look at this is so interesting. Remember that the thickness of that mucosa was about 2.3 to 2.5 millimeters. And what he found that the epithelium was about 0.3 to 0.4 millimeters thick, okay? But the connective tissue at that area was about 1.2 millimeters, okay? So, let's think about it. If we want to, one of the main objectives in the periodontal plastic surgery is, of course, root covering, of course, thick the biotype of the gingival biotype of our patient. But if we only have 1.2 millimeters or less than that, how can we get that gingival biotype so thick as we want to, or our referrals want to do that? That's when you have everything normal, when everything is perfect on the palate of your patient. But start to think about something. With how many incisions do you take your connective tissue grafts? With just one incision? With two incisions? You want to separate the epithelium for the connective tissue? What if you have rugas palatine at that when you want to get that connective tissue graft? Or if you have some torus, if you have something like this and you have those irregularities in your palate, the connective tissue graft that you're going to get is going to be thicker than you want. So let's make a resume about this palatal artery and let's start to think, how much are we getting? The mean height of our connective tissue graft taken from the first molar, from the gingival margin of our first molar, is about 12.3 millimeters. But you never take the connective tissue graft from the gingival margin because there is a sulcus depth. And how much is the sulcus depth on the first molar? Is about 2 to 3 millimeters. So let's start to raise these numbers to this. And remember, under the sulcus there is a biological width that is composed by union epithelium and connective tissue. There is about 2 millimeters. And you have to keep a safety margin between your graft and the palatal artery. And let's be pretentious and just take 1 millimeter of safety margin. If you take those numbers and rest to this number, is going to be about 6, in the best case about 7 millimeters height. Okay? Let's keep in mind that. How much tissue we can get from the palate? Okay, sometimes we can get a lot of tissue, but if we have to think that the tissue or that graft is going to shrink, and is going to shrink about, in the best case, in 15 to 20%, but the mean thickness of those connective tissue graft is about 25 to 40%, we want to get 25 to 40% more that we need to. Okay, and that's the only alternative that we have for periodontal plastic surgery, and the answer is no. There is a new material, or no new material, there is a material that is going on the market for about 30 years. There was only one company that has this dermal matrix, this acellular dermal matrix grafts in the market, but from maybe to 7 to 8 years from now, there is a lot of companies offering this kind of dermal grafts. Now, what is important? Why is the dermis tissue important, or why could be a substitute for connective tissue grafts? Let's start for this. The dermis tissue, it has a lot of things on it. It has nerves, it has microvessels, it has connective, it has a fatty tissue like glandular tissue, it has some follicular hair that you can see here. And there is something really important that you need to understand if you want to use these dermal graft materials. Here is the dermis. This pink area is the dermis. Okay, the dermis that is in contact with epithelium, we're going to call the basement membrane, or in the dermal graft, we're going to call like dermal side or membrane side. And the other side of this dermal graft is in contact with this deep tissue. This deep tissue is also known as reticular tissue or reticular side. That is so important. Why? Because the dermal grafts have sides, and you can't put the dermal graft as you want to. No, always you want to put the membrane side, the basal or the basement side or the dermal side against the epithelium or against the flap that you're doing, and the reticular side is always located against the tooth, against the implant, or against the bone graft that you're going to use. That's so important. What is really important about the dermis, or what are the properties of dermis that are really important for us? There is a lot of things. There could be or could bring us protection, resistant to mechanical stress, thermoregulator, maintains and support capillary and nerve bond. It has sensibility and could give us nutrient transport. And what is important about it? These or those are the main properties that we need from that dermal graft to our tissue. It could have resistance to mechanical stress. Remember that a few years ago, and when I'm talking a few, I'm talking about 20, 30, or 40 years ago, we talked about the keratinized tissue was the only thing that could resist mechanical stress. And you can see the patient that has a lot of grafts, huge graft that not always heals so good. But that was just for mechanical stress, and we can do that with dermal grafts. This is really important because maintains and supports capillary and nerve network, and it could help to nutrient transport. I'm going to talk about three types of dermal graft that we have on the market. The first dermal graft that we have on the market, and the oldest one, is Alloderm. Alloderm is made by a company that is called LifeCell and is distributed around the world by Horizons. Alloderm has two kinds of membrane of dermal matrix: a thin dermal matrix that is called Alloderm GBR, and a thick Alloderm that is called Alloderm itself. What is the thickness of this acellular dermal matrix? In the thin one is about 0.6 to 0.8 millimeters, and the thick one is about 1.6 to 1.8 millimeters. Okay, there is something that you need to know about Alloderm. At the beginning, Alloderm, there is a lyophilized dermal matrix. Okay, so when it's lyophilized, that dermal matrix can't be sterilized. Okay, Alloderm is an aseptic material. Years after, in 2012, they they release to the market alloderm ready to use because it has some process that can have sterility, but I'm going to talk about it in a few moments. You can see here the basement membrane or the dermal membrane or the dermal side of the mucoderm, excuse me, of the alloderm, and here is the reticular side of the alloderm. Here in alloderm there wasn't a sticker on it, and some people think that we have to rehydrate the membrane to remove this sticker. No, that's not the real reason. The real reason we have to rehydrate the alloderm at the beginning, 20 minutes first and then 20 minutes later, was because this matrix, you remember that it was sterile, so they used some antibiotics like you can see here, gentamicin, bacitracin, cefoxitin, lincomycin, polymyxin, and vancomycin. And you have to ask your patient if they have some sensibility to these antibiotics. There is a really nice study in 2002, and let me read what says on it. It says, intact genetic material was present in all 4 commercially processed human allografts. Tissue processing did not completely eliminate intact DNA segments. This is the most important part of it. Remember that in 2002, there was maybe 4 to 6 companies that has dermal matrix grafts, and no one of them has a sterility process. They were all aseptic. They couldn't sterilize the matrix because in the lyophilized process, if they put that membrane or that graft into radiation, the graft or the collagen of that graft is going to break. Here is a microphotography, electron microphotography of alloderm, and you can see how is the collagen structure or the 3D structure of alloderm. Years after that, maybe in 2003 or 2004, Zimmer Dental released another kind of acellular dermal matrix that is called purus dermis. It has almost the same thing that alloderm is thin, again, 0.6 to 0.8 millimeters, and thicker one that is 1.6 to 1.8 millimeters. It comes with the basement side and it comes with the reticular side. But here is a difference. Purus dermis is a human dermal graft, is sterilized, and you can see how is the 3D structure of this graft, and you can see there is more similarities with the connective tissue grafts that we have. Now we have mucoderm. Mucoderm is a porcine acellular dermal matrix. Okay, it has collagen and elastin, and it also has a dermal side and a reticular side. But there is a difference between the other dermal graft. There is just one thickness of this graft. There is only a thick. There is about 1.6 to 1.8 millimeters thickness. Okay. There is something else, and we're going to talk about more forward, that is more stable than the other one. When we talk about purus dermis is stable between 2 to 3 months. This is stable between 4 to 6 months. And you can see here how is the 3D structure of this dermal graft. You can see the channels in here, you can see the pores in here, and we want that the new tissue, the new fibroblast, grows into this mucosal graft or this dermal graft and replace all this structure. Here is a beautiful photography of the histology of dermal grafts when it's prepared. And you can see we want that this dermal tissue remove all the cells, all the follicular hair, all the all the tissue that we have in here, but we need this. These channels that you can see here is the microvessels that are inside the dermal graft, and we want it because we want the new microvessels grows into this mucosal graft. So you can see here a mucoderm, and you can see really clear here. This is the basement membrane, or is the basement side in here at the deep in the mucosal graft. There is the reticular side. How can you compare? How can you know what is the dermal or what is the reticular side? When you suck the dermal matrix in blood, the dermal side is not going to color in red like this, but the reticular side is going to take a really nice red color. You can cut it if you want to cut when it's dry. You can do it, but it's too resistant. When you put the membrane or the graft into the water saline solution, or if you put in growth factors, it's going to be more easy to handle. Okay, as you can see here, and how can well adapt to the defect. Okay, if you take connective tissue grafts, and you take in, I'm sure you have taken a lot of tissue grafts, you can take them like this, and you can take so regular, but in some parts of this connective tissue graft, there is a lot of fat tissue, glandular tissue, and sometimes it's not regular as we want. And what about if we do a profilometry of these connective tissue grafts? And we're talking about aesthetics, okay? And we want that our patient has the same proportion all over the defect. And if we're going to put a connective tissue graft like this, it's going to be thin in here, thick in here, thin in here, thick in here. But if we are going to use a dermal graft like this, it's going to have the same thickness all around the defect that we're going to work on. Now, remember that we talked that alloderm and purus dermis has two sides. It has a thin size between 0.6 to 0.9 millimeters, and the thick size that has 1.6 to 1.8 millimeters. And this is matters also, like the slide says in here. Those size matters. And in fact, the size really matters. I'm going to tell you something. The dermal matrix or the dermal mucosal graft is mainly used in breast reconstructive surgery. Is mainly used in hernia repair surgery. In dentistry, we use it a lot, but it's not the most common use for dermal matrix. So, plastic surgeons and general surgeons had a lot of experience working with this kind of materials. What they found? They found that if we put that dermal graft in saline solution or growth factor or something that returns the humidity to the dermal graft, the volume will increase to 20 to 25% in thickness. Okay, so remember that we talk about 1.8 millimeters mean of that dermal graft. So it's going to be, when we rehydrate that graft, is going to be about 2.0 to 2.1 millimeters in thickness. But even better than that is this, that the tensile strength increase about 50 to 75% when we rehydrate the dermal graft for 20 to 25 minutes. So that's important for us. Of course, we want to suture that dermal matrix to the sides. We want to use it for plastic surgery reconstruction. We want to use it for guide bone regeneration. Okay? Let's see some cases. you're going to see cases we're using dermal graft for about 10 years, and we're going to see from simple case to very complex case. You can see here a patient that has root gingival recessions here in the canine and the premolars. Even here is a crown. And at the beginning, we were using dermal matrix that was human source. We make a mucosal flap, and we cover. And you can see here, 2 years after the surgery, what is the recovery of that surgery. And you can see here, of course, here is more height than here, but remember that this tooth has a crown on it. So I can move the gingival tissue over a crown. That would be a miracle. But you can see here, look at this. Look the color. Look the structure. Look the appearance. Okay? And remember that we have at the beginning a really thin biotype. And remember valvas. Okay, we can do this with just dermal grafts. Maybe we can do it, but it's not going to be so stable. Remember that this has maybe 6 to 7 millimeters thick, so it's going to be impossible to do it with that. So at that moment, we start to use, and this is maybe 8 years old, that we can use or we can combine dermal matrix graft with bone grafts. At the beginning, we use only hydroxyapatitas and xenograft. Okay? This is the result 6 months later, when the prosthodontist start to do some pressure on the gingival tissue. Okay? Remember when we start, look at this resorption here in this ridge. But 3 years later, here's the condition of valvas. And look again. Look the tissue, look the color, look the appearance. Look how is the biotype, and look how stable it looks like. And we start to think, okay, we can use this material. We think it could be more stable than some kinds of collagenous membranes. So we have here Olga. Olga is a team, a staff team from a colleague of mine, and she wants us to do something in here. She wants to have implants in here, but she has a very thin biotype and a huge defect. Okay, so we use again a dermal matrix graft, a xenograft mixed with autograft, and we always use from this point at the end, we'll start to use growth factors. So you're going to see like this. This is 24 hours after the surgery, and you can see how it's healed. And look how is this ridge healing. And you can see here, there is a month after the surgery when we remove the sutures. You can see here. Okay. 9 to 10 months later, we want to see what was happening in there. And you can see here, you can see this. That was the bone graft that we use. And look what is the thickness of this graft? 6.1, 8.2, 8.5, 8.25 millimeters. So we can do a real guided bone regeneration using dermal graft. And this was maybe 6 to 7 years ago. Okay, we're going to guided bone regeneration more forward in the presentation. Here we have another cases of gingival recession. So let's talk about the difficulties. We're talking about gingival recession in molars. How easy is to handle that? Okay, so we start to do a simple coronal advancement flap. Okay, like you can see in here. We use dermal graft with growth factors. That was at the beginning of PRF. Okay, but you can see here, 1 year after the surgery, look how it heals. Okay, of course, here is a small scarring here, a small scarring here, but you can see the appearance and you can see the biotype of this procedure. This is the same patient, but the other side, and you can see here there was more thin biotype, okay, a huge or a big gingival recession, and we do the same thing. We do a coronal abutment flap. We polish that root surface just with burrs. Okay, we put our dermal graft, put our growth factors, and suture. And this is 2 weeks later. And this is 1 year later. And you can see, look at the tissue, look at the color, look at the biotype. Okay, I don't have 100% cover of this gingival retraction, but remember where was the papilla at the beginning? There was a class 3 recession, so it's going to be impossible to have 100%. So let's do our life more difficult, and we were taking more experience, and Anna came to us. She was a lady from about 60 to 70 years old, and she wanted us to cover this canine like you see in here. Okay, can you see the biotype? Can you see the gingival recession? Okay, so what we want to do is a lateral slide flap, and we want to use, of course, dermal matrix. Okay, we polish our root surface, just burrs. We don't use ETA or endogain or nothing different from burrs and growth factors. We put our dermal matrix. We use growth factors and suture, an easy surgery. This is 24 hours after the surgery, and you can see the recovery of this. And now we have more experience, and you can see how it heals. This is 2 years after the surgery, and you can see what was the cover of this root surface. And there is almost impossible to see a scar in this area or in this tissue. Okay? And look at the biotype. It's really good. Can you get that with connective tissue grafts? Maybe, but not always. Remember Juliana? Juliana was the girl that her parents were dentists. I'm going to show you what was the baseline of this case. You can see here the thin biotype. You can see here the gingival recession of this patient. Can you put the video, please? This is about 7 minutes video, and so in some parts I'm going to move it forward so we can do the time that we need just for 1 hour. So we have a special instrumentarium that we're going to use to need this. We have a very small or a microsurgery scalpels that we're going to need. Can you see here? Can you see here how is the thin biotype of this patient? At the beginning, here we're removing the cervical restoration that the patient has, but we also are eliminating the sulcus epithelium and the union epithelium of that sulcus. Here we're using the microsurgical blades. Remember that we have a really thin biotype. I'm going to move forward. We use 15C blade to connect these cuts that we do at the beginning. I'm going to move it forward. So we have time to discuss at the end. We raise a complete flap, a total flap. We want to do a mucosal in a mucosal flap that could be handled or that has tension free. As you can see here, there is a lot of tension of that flap. So we need to be better in that. Now we have to reshape. This is the apex of the premolar of the left side. Now we want to reshape those roots. We have to remove those epithelium, and we use a mucoderm graft. Here you can see the base or the basement side of this dermal graft. In here, can you see how is red color? That's the reticular side. We use growth factors, and we start to suture. I'm going to move forward. I want you to check how is the healing. Here is at the beginning of at the end of the surgery. Okay, you can see the cover. You can see the thickness of this biotype just after the surgery. And this surgery takes about maybe 1.5 hours. Okay, 24 hours later, 1 month later, you can see the biotype. You can see how is the root cover process. And sometimes you see those papillas, and some people get crazy with that. And just have patience. In mucogingival or in periodontal plastic surgery, you need to have patience. And you're going to see how this papilla and this papilla are going to heal really good. You can see here, 3 months. 3 months. 6 months after. And let's keep waiting. Just keep do the maintenance of your patient and keep waiting. Let's see, 2 years after. Look the papillas. Look the papillas. Look how it really how beautiful healed these papillas. Just maintenance. Okay? So I want to show you before and after pictures. This was at the beginning. This was 2 years after the surgery. You can see the biotype. You can see the gingival recession almost covered, maybe 95 to 96%. And at the other side, look at the papillas. Okay, look at the biotype, a thick biotype. Look how thin was at the beginning. Now let's keep talking about guided bone regeneration. This is Patricia. Patricia, she's a civil engineer. She learned how to use helmet after this incident. She rocked from the roof, fell in her face and hit her face, and she had a root fracture here in the central incisor. You can see the CT scan. She had a root fracture and she has no bone at all at this case. So we raise a huge flap, we extract the tooth, we can see the vertical root fracture, and we say, okay, we can do our dental implant and we can do our bone graft and we can get better gingival biotype. So we put the implant in the correct position, 3D position. There is a lot of things. We put our implant. We use bone graft exclusively. In this case, we use xenograft and growth factors. And we let healing abutment at this time. And we put our dermal graft. Okay? This was maybe 6 years ago. So we use this really good, really big dermal graft. We cut it in two and we put this dermal graft over the healing abutment because we don't want to close the flap at all. So this is after the surgery. Here you can see the dermal graft in there. Okay. Now you can see this 48 hours later after the surgery. In this, at the right side of the screen, here is 6 months later. You can see here there is maybe some retraction or there is some resorption of the bone graft. Just keep waiting. Remember where is located the implant is at the palatal side, okay, and it is just a healing abutment. We haven't do the profile of this tooth. Okay, at the moment of the second surgery, the prosthodontic doctor do this temporary crowns over the implant. We have this scarring here, so we have some electrosurgery to eliminate this scar. And you can see here the patient 6 years after the surgery. Look at the thick, really thick biotype. Look at here. Look, this is the natural tooth, this is the dental implant. This is the best slide that I have for this case. This was at the beginning. Remember, this is the tooth and there is no bone at all. And look at this. Here is the implant. Here is the abutment. Here is the line of the prosthetic termination. And here I'm going to paint like this. Here is the bone graft. Do it with xenograft and dermal matrix. Now, can we have root covering procedures with this kind of dermal matrix? Of course. We can have almost, I'm going to do fast and have only 4 minutes. We can have almost 83 to 96.6% of root coverage in class 1 and class 2 defects. Now, you heard that I use growth factors since 6 years from now. Why? Because we have a lot of growth factors that could be sustained or could be maintained in this kind of procedures. And you can see that I show you picture from 24 to 48 hours after the surgery, and there was a really good healing of that process. Now, can we combine techniques? And you can see here, this is Natalia. Natalia is a really beautiful lady of here in Medellin. She's a model. After orthodontist, she has this problem, and the orthodontist called me, Andrés, we have this problem, but I told you, and you have this problem too. You have a really thin biotype in this area. Look at this. Look how is this located, how his tooth is located. So we do a combination of techniques. We do a dermal graft material here to do the to cover the gingival recession, and we use bone graft to augment the thin biotype that this patient has. We do a lateral slide flap, and this is the healing 24 hours after the surgery. And you can see here, this is 1 year after the surgery. Remember that our tooth with the gingival recession was this, okay? Remember that this is going to heal really good. Just give it some time. And you can see the biotype. Remember how we start. Remember how we end 1 year after. Now, let's talk about cell migration. And we can talk about matrix or dermal matrix resorption. We have to talk about matrix degradation. Remember that the matrix has collagen and elastin inside it, and there is channels that is going to allow the microvessels in growth into the dermal graft. Here you can see a really nice microphotography from day 1 to day to 4 months, in how the connective tissue and how the microvessels in growth inside the dermal graft. Here is a beautiful slide of it. This is a channel that I showed you at the beginning of mucoderm. Here is the basement membrane of that dermal matrix, and here, this red highways, as you can see here, I call it highways because it's really beautiful, is the microvessels that ingrow inside the dermal matrix. Now, how can be degraded, or how fast it degrades? It maintains their thickness between 1 to 2 months, and after that it's going to degrade until it takes about 6 to 8 months. What happens about the endothelial cells? In many studies, it shows that mucosal graft or dermal mats increase the vitality of endothelial cells. I'm going really fast, I know. There is a resume, or I see a lot of questions there. There is some experience about it. There is the last year experience that we have with this kind of material. And you can see here that we have 44 patients with 140 sites. With almost the proportion between men and women are the same, but here is something important. There is no single patient that was a smoker. This is so important for us. There was the recession class that we have, class 1, class 2. If you give me 2 minutes more, I'm going to finish. This is the mean gingival recession that we have at the class 1, 4.2, and class 2, 4.3, and class 3, 3.8. I'm going to show you this. What was the mean root coverage that we have with dermal matrix? In class 1, we have 92.3% of root coverage. In class 2 was about the same, 92.1%. In class 3 was about 66.5%. There is a paper from American Academy of Periodontology that tells, I'm going to read here. Coronally advanced graft plus acellular dermal matrix graft, enamel matrix derivative, or collagen matrix led to the best improvement of recession depth. This is a new thing because some years ago no one believes in dermal graft. Now we can see a really good results. I'm going to finish with this case. This is the last one because this is my first case when I use dermal matrix. This is about 10 years ago, because some people ask me, how stable is this? And you can see here is a patient about in the middle of 50s. He is class 3, he's prognatic patient. He don't want to do orthodontic surgery. And the orthodontist told me, Andres, we need to put this teeth to the lingual side, but we're having problems in here. And you can see there is no keratinized tissue in this area. So we do our mucogingival flap, we do some bone graft on the vestibular side, we use dermal matrix, we suture, in some cases we leave it exposed. And what happened? Here is after the surgery. And 6 months later, this is the case of Jaime. And you can see how is this biotype. I don't want to cover it, I can't cover these gingival recessions, but you can see this biotype. Remember when we start. This is the last week. This is the past week, 10 years after. You can see this biotype. You can see the stability from 10 years when we use this kind of material. So, is it stable? It's really stable. Now, to finish, all dermal matrix that we have on the market are equal? No. They have the same strength? No. Is the same source, or is the same if I use human source or animal source? No. Is the size and width important? Of course. Do you recommend to use growth factors? Always, especially when we're talking about periodontal plastic surgery. All the dermal grafts that we have on the market are sterilized? No. Do you know the process? Oh, this is a question for you. Do you know the process that the dermal matrix that you're using? Think about it. Think about the purity or the antibiotics that you have on the matrix you're using. You have to know how is the inflammatory reaction of this dermal graft. There is a lot of cases you can do in this with this material. There is a new horizon in this case. In fact, in my practice, there are less cases that I'm using pericardium or collagen membranes, and I'm just using it mucoderm dermal graft. And if you're going to start to use it, it's a really good material. Thank you so much for your attention. I have a lot of questions in here, and I'm trying to answer as best I can. Dr. Pavan Kumar. Okay. Dr. Pavan Kumar asked, what is the thickness of ADM? If you're using human dermal matrix, the thin one is about 0.6 to 0.8 millimeters. And if you're using the thick one, it's about 1.6 to 1.8 millimeters. If you're using mucoderm, it's about 1.6 to 1.8 millimeters and just have this thick. The Dr. Jose Dominguez Mejia says, there is experience on this matrix covering bone graft in very thin biotype, like in posterior area, like in inferior posterior area, and yes, there is a lot of experience, there is a lot of papers on that. I don't show any case on that area, but you can see how bone graft comports or works with dermal graft. In the last case, we are really thin biotype. And there is a paper from maybe 2014 for Dr. Tarnow showing bone regeneration using bone graft, xenograft with dermal matrix. Dr. Brian Pangugen asked, which side is face bone dermal or reticular? Remember that the dermal matrix has two sides. A dermal side that is with it has some pores on it and it doesn't come red when you soak it in the blood of the patient. That side, the dermal side, that side that is so white, it has to be against the flap, not against the tooth or the implant. The reticular side, that is the side that is going to get really red when you soak it in the blood of the patient, is going to be against the tooth or against the implant or against the bone graft. Dr. Malik Kabaham has 3 questions. I'm going to start for the first one. The first one is, how much does dermal matrix shrink through healing? Now, the dermal matrix doesn't shrink. The dermal matrix, remember that slide that I showed you, it doesn't resorb, it does degradation. The matrix has degradation, so it doesn't shrink. There is a common thought that the dermal matrix shrink and they doesn't shrink. They degrade and the new tissue is going to grow inside the dermal matrix. Now, the second question is, do we have to do full thickness flap or partial thickness for dermal matrix to be placed? It depends. If you have a very thick biotype, you can do a partial thickness flap. But if you have a very thin biotype, like I showed you in the last cases, you have to do a muco or a full thickness flap and then do a partial thickness flap. The last question of Dr. Malik Kabaha says, what is the best for getting a keratinized gingiva CT graft, pre-gingival or a dermal matrix? Thank you. There is some doubt that I have with dermal matrix. With dermal matrix, there is no indication for keratinized tissue, but you can see in those cases that I show you, especially the cases that has a lot of time, there is increase of keratinized gingiva. Why that happens? I don't know. There is some cases or some papers that say that this dermal graft put on like a free gingival graft can heal like a keratinized tissue. I've never seen that, but it could happen. Now, getting back in your question, I think that the free gingival, it could be a better approach to get keratinized tissue. Dr. Moss has like 3 or 4 questions. The first one is, think these results are reproducible in most cases? Yes, of course, but the dermal matrix graft has a learning curve. You have to do hands-on, you have to do workshops, you have to train a lot before you start to work with this kind of material, because it's too thick. When you soak it in saline solution or in growth factor, it's going to grow about 25%, so it's really difficult to handle. But if you have the experience and you are every day is getting better in this case. So is reproducible? Yes, of course, if you choose the patient right. There is another question. Is there a need to mix the body's bone graft with patient bone graft as well? Depends. If you just want to do a pontic side, like I showed you in Balba's case, you can do just xenograft. If you're going to do a big case and you're going to do a really big bone graft, I suggest you to combine xenograft with autograft, maybe 50-50 or maybe 70% of Cerabone and 30% of autograft. Dr. Moss again. Great biotype, but think these results are reproducible in most cases? I think I responded in a few questions before. Are there any other reference you can provide, please? Yes, of course. If you send me your email, I would be happy to send you all the papers that we have with dermal matrix reproducible cases. Alexander Gansin, thanks a lot. Thank you, doctor. The same says Dr. Fadi Musa, thank you so much. Avilev, thank you so much. Fadi Musa, Dr. Fadi Musa asked, is dermal matrix a 100% alternative to CTG? I think at this time, yes. If you are not trying to get keratinized tissue, if your main concern is get keratinized tissue, maybe it's not the case to use dermal matrix. But if you're asking me, Andres, have you ever done a CT graft in the last years? Maybe 2 or 3. Why? Because the patient don't have the money to pay for dermal graft. That's it. And if I have to repeat surgery because the patient was a gingival recession in here, and 1 year later she wants to do in the other side, most of the patient that goes with CT graft tells me, Andres, let's go for dermal matrix. Dr. Nazar Babinsky asked, what you can explain about main rule in guided bone regeneration? That we need to cover bone graft by non-resorbable membrane, but I think that this is not the topic of this webinar. But if we need to cover the bone graft always with membrane, not always. If we use growth factors and the defect is a small one, and when I'm talking about the small one, I'm talking about no more than 4 to 5 millimeters, we can use growth factors. If the bone defect is bigger than that, and we need to maintain space, we have to use non-resorbable membrane, maybe, or you can use dermal graft. Dermal graft is a really good space maintainer. I don't know if I answered that question. Is there any more questions? If no, I think we're okay. Thank you, Dr. Babinsky. If no, I think we're finished. Thank you so much for your attention. Bye-bye.
Thank you very much, Dr. Eslava, for sharing your lecture and your insightful information with us. We would also like to thank botiss for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions for Dr. Eslava may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Eslava will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform www.botissacademy.com and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.